Hi, my name's Rob Phillips. I'm from the University of Queensland in Australia, and it's my pleasure to talk with you virtually today and address the General Hospital Tianjin Medical University, Tianjin. And I'd like to thank the organisers for inviting me to come and apologise that I can't be there in person. But I'm with you in spirit, and hopefully you can enjoy my presentation almost the same as if I was in person, and I look forward to joining you next year. What I want to talk today about is oxygen delivery and its relationship to cellular demand and disease in the emergency department. To state the obvious, oxygen is important. We cannot live without it, and at many levels it determines our outcome and defines ultimately our death. If we look back to 2019, what was very important from my point of view, as I've spent my life researching this particular area, was the Nobel Prize for Physiology and Medicine, going to Drs. Samantha Ratcliffe and Kalin. And what was amazing was that they actually discovered that every cell in the body has a sensing pathway that communicates to the brain about its location and its oxygen requirements. So every cell in the body is an oxygen sensor. And this shouldn't be surprising, because we know that muscles, for example, communicate that they need more oxygen in exercise. We communicate to vasodilate during exercise, and various thermoregulations when the temperature gets hot, and also in erythropoiesis, and also to manage the immune system. So it's clear that there is a communication between the controlling system and the sensors themselves. It's just a matter of proving it, and this was the exciting result from the Nobel Prize last year. Importantly, from a clinician's point of view, of course, is that these cells function and their messaging changes in disease, such as in sepsis, renal failure, heart failure, cancer, etc. And the messages that they send and the demands that they make change in all of these conditions. So it's our responsibility to better understand the messaging and what the messages mean and meet the demand. Let's look at the fundamentals of oxygen and oxygen circulation, if you like, from photosynthesis through respiration, and a most remarkable process that's complementary between vegetation and animals, and that is respiration takes in glucose and oxygen and creates carbon dioxide, water and energy, ATP, the energy, the driver of life. But with those byproducts, the carbon dioxide and the water add light, and suddenly we get glucose and oxygen in return. So an absolutely complementary relationship. And importantly, 5 trees generate enough OT for 1 person. Let's look a little bit closer now. There are approximately 30-35 trillion cells in the human body, of which 25 trillion are red blood cells, and another 4 or 5 trillion are related to the vessels and to the heart and the respiratory system. So the circulation takes up maybe 90% of all the cells in the body. This is quite remarkable. What it means is that 90% of the body's cells deliver oxygen to the other 10%. So our body is actually an oxygen machine. It generates oxygen just to keep alive those 10% of those cells. And that's incredible, because it suggests that the respiratory process from the lungs to the heart is absolutely vital. So much of our body is devoted to it. And each heartbeat delivers the oxygen to support 33 trillion cells. If we look at what does that mean in a clinical context, from the pathway of oxygen entering through the lungs being absorbed into the blood, pumped by the heart through the vessels to the microcirculation, and ultimately to the biochemical transformation of oxygen to ATP, what we can see is what role does the clinician have in this pathophysiologic process. And if we interrupt that process for more than 3 minutes, then the cells begin to die. This is obviously a critical pathway. So increasing DO2 and decreasing consumption, VO2, and metabolism may play an important part in how we manage many diseases. Importantly too is that the heart and the vessels are the prime movers of oxygen, and it's fluid and inotropes and vasoactives that regulate the vessels, fluid and inotropes which regulate the heart. So this is our therapeutic pathway to manage the circulation. And so understanding what goes wrong with the disease processes and how that impacts the oxygen pathway, and understanding how our interventions and therapy can modify and regulate those dysfunctions is absolutely central to improving our critical care. So the human body is an oxygen delivery system. Interrupt the supply for more than 3 minutes and the cells, organs and the organisms begin to die. This is critical care. Importantly, hemodynamics is at the root of all of this. Hemo is blood, dynamics is flow, and it's the red blood cells that are being carried around in the blood flow, and it's the red blood cells that are bound to the oxygen. So the 25 trillion red blood cells being pumped every beat around our bodies is delivering oxygen, and we can measure the effect of that by measuring the stroke volume, cardiac output, and the oxygen delivery. The vascular tone all provides us with the information that allows us to understand what is going on in the circulation. If we look at the circulation from another point of view, and what we can see is about 1 litre per minute of oxygen is pumped around the circulation. So a litre per minute goes through the arteries, it goes to the cells, and the cells take what they want, which is about 0.25 of a litre per minute, and return the 0.75 litres per minute back to the lungs. And the lungs have to complement that with the oxygen from the air and restore the oxygen content to a litre per minute, which then goes around the cycle. It's a Fick equation which shows us that cardiac output, which is stroke volume times heart rate, equals oxygen consumption over the saturation of pulse arterial oxygen minus central venous oxygen saturation. So knowing arterial saturation and the venous saturation, we can understand the delivery and the carriage of oxygen around the body. Oxygen delivery, DO2, is a function of a correction factor, hemoglobin in the blood, the stroke volume and the heart rate, and of course the saturation of the blood in the arteries. The oxygen consumption, of course, is the pulse arterial saturation minus the central venous, the saturation of venous blood, oxygen in the blood, times by the cardiac output, which is stroke volume and heart rate. What we can see is that the stroke volume is absolutely critical to this whole transportational process. So understanding the stroke volume is understanding the circulation. Importantly, oxygen extraction ratio is becoming a modern measure of understanding how efficiently the circulation, or the microcirculation, extracts blood from the circulating system. It's not simply enough to provide macrocirculatory oxygen. We need to have microcirculatory processing so that it can be delivered and converted in the mitochondria to ATP. So what does this have to do with the emergency department? Well, let's take the example of COVID-19. And what we know is COVID is both common and dangerous, and it's widespread. You can see that cases are rising and deaths are rising, and it's become a factor of modern medicine which impacts every clinician's existence, particularly in the emergency department. Understanding COVID will allow us to better understand sepsis and most oxygen delivery diseases. So if we look at comorbidities in COVID, and this is fascinating, if you've got cardiovascular disease, hypertension or diabetes, then you have an increased risk of mortality with COVID-19. If you have them all, you've got a 40% risk of mortality. Whereas if you've got a comorbidity of the lungs, which I would have thought would have been much more important, given that this is a respiratory tract infection, then you only have a 1.5% chance of dying. So 40% with cardiovascular disease, 1.5% with lungs. So somewhere along the pathway from becoming a respiratory tract infection, it's basically a cardiovascular disease. And if we look at the data, what we can see is cardiac dysfunction plus COVID-19 is a 10 times increase in mortality. Cardiac dysfunction and COVID-19, again, 50% on ventilated patients. So all patients who have cardiovascular comorbidities have significantly increased mortality risks by a factor of 10, which is an incredibly high number. If we look at, again at acute cardiac damage, so cardiac damage plus COVID-19, then you've got a 70% mortality. Again, 10 times that of just cardiac disease alone, of no cardiac disease. So this tells us that in COVID, cardiovascular system is an absolutely critical component of improving management. If we look at the mortality of COVID and the age-related mortality, what we can see is older folk have a higher mortality. And if we look at the incidence of CVD by age, at each decile, then our incidence of cardiovascular disease increases, as does our incidence of COVID mortality. So it's not too great a stretch to propose that cardiovascular disease is a determinant of outcome in COVID, and as such, its improved management, better management of cardiovascular function at all stages is likely to result in improved outcomes. So let's look at what happens to the circulatory system during infection, and this includes COVID. Normal circumstance, VO2, which is the oxygen demand, is met by oxygen delivery, which is DO2. So the blood pressure is normal, stroke volume and heart rate are normal, and systemic vascular resistance are normal. So if we get an infection, what happens? The oxygen demand increases. So to meet the oxygen demand, then the stroke volume and the heart rate may increase. Systemic vascular resistance decreases, i.e. the vessels dilate, reducing tone, and that all leads to an increase in oxygen delivery, which again matches the increase in oxygen demand, VO2. So this is compensation in sepsis. Now, what we do know with sepsis, and what makes sepsis so dangerous, and maybe the confounding issue in COVID, is that the process of infection, the immune response to the infection, releases various mediating proteins. And the most common, well-recognized one is the cytokine. And the cytokine is a mediator which is known to depress myocardial function. So it will depress stroke volume. Now, if we've got an increased demand and we've now depressed the stroke volume, we now have a oxygen supply-demand mismatch. What else happens in sepsis, and particularly, say, in COVID, is that vasoplegia is induced by the ACE2 pathway interference with the COVID receptors plugging into the ACE receptors. And this causes a vasodilation, a lack of conversion to angiotensin II, so a lack of vasotone, and the vessels become vasoplegic. So now we have an increased oxygen demand, we've got cardioplegia, and we've got vasoplegia. And now we have hypotension and a significant demand, oxygen demand supply mismatch. And this is the very dangerous stage of sepsis. But understanding that relationship allows us to detect during the compensated phase the abnormalities of stroke volume and systemic vascular resistance. If we look at a hypothetical timeline and see what happens, in the first instance, VO2 oxygen demand goes up. So what happens is the stroke volume index goes up to meet that oxygen demand. To complement that, the systemic vascular resistance goes down, so it vasodilates to reduce the resistance and provide less power to drive the increased oxygen demand. What we see is the blood pressure remains normal, so normotension, but with a adjusted circulation. Stage 2, of course, is when the function of the heart begins to diminish and stroke volume starts to drop off, in which case the systemic vascular resistance in an attempt to preserve blood pressure increases. So now you've got dropping blood pressure, increased SVR and a decreased SVI, and a further increasing VO2. So the demand keeps increasing and the circulatory system is doing its best to meet the increased demand. If we look at these two examples a little further, what we see is vasoplegia on the right and cardioplegia on the left, and we can see that they have different time courses and they have different pathways, and at different times stroke volume performs in a different way to systemic vascular resistance. So what this tells us is the underlying pathophysiology of sepsis, and say COVID as well, demands that we understand stroke volume, systemic vascular resistance and oxygen delivery. The interplay of all of those physiologic parameters will determine the success of the organism in providing adequate oxygen to meet the increased demand and ensure the survival of the patient. So patients are different, the septic responses are different, and so the monitoring and the measurement and the therapy needs to be different also. If we look at how we do treat cardioplegia and vasoplegia, it's quite simple. Fluid and inotropes for the heart and vasoactives for the vessels. And we know that fluid is the most common critical care intervention and is often inappropriately delivered. So we need to measure the stroke volume to understand A, whether fluid is necessary, and B, how much fluid we need to give before we stop. Systemic vascular resistance, of course, is mediated in part by the autonomic nervous system, as is the stroke volume and the heart rate. So it's a complex interplay, and the only way we can understand it and decide the appropriate therapies is to measure stroke volume, systemic vascular resistance, oxygen delivery, and cardiac index. So what happens to the stroke volume during disease and during therapy is a simple model, and you will see at the top the impact of fluid, in the middle the inotropes, and below vasoactives. And remember that the principal vector of oxygen delivery is stroke volume. So better understanding how the stroke volume works and responds to treatment is absolutely critical if we're to optimize treatment. So for fluid euvolemia, we've got a normal stroke volume in the middle. Hypovolemia, we've got a diminished stroke volume. If we keep giving fluid to the hypovolemic patient, they will become euvolemic as their stroke volume increases. But once we pass the threshold of the Frank-Starling curve, then the stroke volume will begin to diminish again. And this is a very useful physiologic response to an intervention, because it tells us what's the optimal fluid loading for that individual patient. And the answer is the point at which the stroke volume is maximal. So that's very simple, when you need fluid and when to stop. In the middle, we've got the inotropes, and what we can see at baseline, we have a normal cardiac output. If we give a negative inotrope, then we can depress that stroke volume. If we give it a positive inotrope, then we increase the stroke volume. What happens there, of course, is increased oxygen delivery, increased stroke volume, increased cardiac output, and a decreased systemic vascular resistance. If we look at the vessels, a baseline, we've got a normal cardiac output. If we vasoconstrict and increase the resistance, then the stroke volume diminishes, as does the cardiac output. Systemic vascular resistance increases, but oxygen delivery is decreased. So vasoconstriction can work against you in a therapeutic sense, even if you need to have a vasoconstrictor to preserve blood pressure. Remember, it will reduce your oxygen delivery. If we look at a vasodilator, of course, you reduce the resistance. Your systemic vascular resistance drops, stroke volume rises, cardiac output rises, and your DO2 rises. So each of these things give us a better understanding as to what we need to do and how we need to intervene. Now, if we take that information, we can apply it in simple physiologic models. And the idea is to develop precision treatment models based on personalised physiology. And this is a simple one about fluid, and that is we look at the stroke volume. If the stroke volume is low and the stroke volume variability is high, then give fluid and observe. So you monitor, give fluid and monitor, track around the cycle until the stroke volume is normal and the stroke volume variability is normal. And then you've reached the end point. Check the oxygen delivery is normal and there's no absence of red blood cells. And basically we've optimized the fluid flow. But what it requires is a very accurate measure of stroke volume, and it's Doppler monitoring which provides that highly accurate, very responsive readout as to the mechanics of the cardiovascular system and its optimization of the stroke volume. Now, if we go forward a little, we can actually apply a slightly more complex protocol, physiologically precise protocol, and that is we have a fluid arm where we do exactly what we did in the fluid protocol, but we also have an inotrope arm. So if we are euvolemic after having done the fluid optimization, but the stroke volume is still low, then we should try an inotrope to increase the myocardial contractility. We follow that pathway around until the stroke volume is normal, the fluid is normal, and then we look at the systemic vascular resistance. And if the systemic vascular resistance is low, then you vasoconstrict. If the systemic vascular resistance is high, you may need to vasodilate. And the end point, of course, is to ensure that oxygen delivery is optimized. And in this case, 500 to 700 is about the right value for most normal patients in a normal physiologic state. If we now approach sepsis, things get a whole lot more complex once we get to this stage. What we do know is there is increased oxygen demand of the organism associated with systemic infection. And so we have to ensure that the cardiovascular system actually upregulates therapeutically or autonomically. And so again, we go back to the fluid inotropes, vasoactives, vasoconstrictor, vasodilator, and measure the DO2 as an outcome of that. But if you follow the pathway through, ultimately what you get to is an optimal oxygen delivery, somewhere between 700 and 900. So by understanding the way the stroke volume, systemic vascular resistance, the cardiac index, and the oxygen delivery interplay, we can guide with some degree of precision the therapeutic interventions which will optimize interventions and outcomes in fluid, in heart failure, and in sepsis. The important thing about this, of course, is does it work? And this year with the COVID events, it was the Chinese National Health and Medical Commission of the People's Republic of China that recommended non-invasive Doppler stroke volume monitoring as the preferred method to guide treatment in COVID cases. And this Doppler monitoring in sepsis has been a function of clinical care since originally with SARS. And it was the same principle there. This is a sepsis that interferes with the circulation. So understanding what the circulation is allows you to make more precise decisions about how to intervene. And this was the reason that non-invasive Doppler monitoring was the preferred method to manage these COVID cases. And there are now something like 60 or more hospitals and centres throughout China that are specialised for infectious diseases and their management. And the same process now is starting to happen in Europe. They are focusing, and Doppler monitoring has become a preferred technology. And the US as well is starting to happen. So, in summary, adequate O2 is essential for the survival of the cell, the organs, and the organism. And inadequate O2 results in dysfunction and potential death of the cell, the organ, and the organism. And much of acute care is directed to ensuring O2 is effective and adequate. But we need to monitor stroke volume, systemic vascular resistance, cardiac index, and DO2, because it is the oxygen demand, the lack of meeting that demand, which increases mortality. And basically, managing that process is essential to optimal care in critical care environment. So thank you very much for this opportunity to speak with you. And as I say, I apologise for not being with you in person, but maybe next year. I look forward to it. I've got many friends in Tianjin. So I wish you to have a great conference, and I look forward to meeting you all again next year. So thank you very much.